in your office on your own. So we're able to see people without masks. I actually don't recognize you without your mask, I must admit. No, I'm only joining. I'm joking. Well, Edna, and to everybody online, the emergency department teams, and in some of the hospitals, the teams have joined as one person, but are sitting with a few people in the emergency department. We're back on the line with Edna and her team from Sanofi, looking at the pertussis and tetanus vaccine as a one shot for certain patients in the emergency department. I think the presentation we heard previously has not been heard by these people, and I'm excited and looking forward to your speaker, who I heard for a few seconds on the Skype earlier, on the meeting earlier on, and really welcome both of you and the emergency department teams to see how we can go forward, and if we are going to go forward on the combined vaccine, obviously with an increased amount of pertussis in the country. And as vaccines are the point of much discussion at the moment, I'm sure that this presentation will also assist us to make decisions on how we're going to go. So thank you very much, Edna, and I'm looking forward to the presentation.
Thank you so much, Mandy, for that lovely introduction. Good morning, everybody that is online. Thank you so much for taking the time to join us this morning. And true to Mandy's word, I mean, you know, vaccines is a very topical issue as of late, you know, with the current pandemic. So we as Sanofi Pasteur, which is a vaccines manufacturer, decided, you know, we need to team up with Netcare, the biggest hospital group, and have conversations regarding increasing vaccines coverage rates of diphtheria and pertussis within the emergency departments. So with that said, we approached Mr. Mngengeli Sibanda, who's our speaker this morning. So just to let you know, who is Mr. Sibanda? So Mr. Sibanda is currently employed at the University of Sefako Makgatha Health Sciences as a lecturer. He has an avid interest in vaccination, and he's completing his thesis, his PhD, is a PhD candidate, and his thesis is titled Vaccination Uptake Amongst Geriatrics in South Africa, not that we are the geriatrics. So Mr. Sibanda will take us through, like I said, the importance of increasing vaccine coverage rates within the emergency department of diphtheria and pertussis. Take it away, Mr. Sibanda.
Thank you very much, Edna, and thank you, Mandy, as well, for the kind introduction. So yes, if you can just allow me a second just to project. Okay, there we go. I hope my slides are visible.
Yes.
If I can just get an indication.
Yeah.
Great. All right. So as you rightly introduced, Edna, the topic for today is how we can increase coverage rates for diphtheria and pertussis vaccine within our hospital setting, specifically in the emergency department. And this is just a small disclaimer about the presentation that we are having today. So it is basically medical education, and the views of this presentation are mostly academic, and they do not necessarily reflect the position of Sanofi. And of course, as usual, we'll be opening up for questions at the end of the session. I'm not sure if you would like the participants to type in questions as I go along, or should we just save it for right at the end, Edna?
I think all formats are fine. So if people feel comfortable typing questions, we can do that. Or if they want to have live questions at the end of the session, that's also okay.
Okay, wonderful, wonderful.
Perfect.
All right, so without wasting much time, this is just an overview of what I'm going to present about. Just going to briefly remind us on, you know, the diseases and their presentations as well as their epidemiology. So tetanus, diphtheria, pertussis. We're also going to talk about the risks in our workplace setting. So it's occupational exposure for us as healthcare workers. And of course, the vaccine strategies that are available And then lastly, we'll conclude with just touching on routine immunization during this pandemic. Right, so we all know that with increasing age, we experience a phenomenon called immune senescence, whereby our immune system, our natural immune system, deteriorates over time. And also, what also happens is the vaccines that we've gotten as children are not as effective. That means their immunogenicity has waned, it has gone down. And because of this, what often happens is that adults, particularly those of older age, experience or are likely to be prone to diseases that are vaccine preventable. This is because of the waning immunity that happens over time. If we specifically zone in on tetanus itself, so this slide just basically shows that over time, at the bottom there, you see the increasing age groups. But with increasing age, what we see is that there is also a decrease in immunity against tetanus, which is exactly the phenomenon that I spoke about earlier on. This just reiterates that even with increasing age, there are more fatal cases of tetanus as you get older. And then if we zone in on diphtheria itself, we all know the presentation of diphtheria. It is passed on by respiratory droplets, and it presents as a pseudomembrane. It's like a plaque right at the back of your throat, in your pharynx. And what happens with diphtheria is that it is obviously prevented through a vaccine, which is given in infancy. But as we see here on the slide from 2018, there were outbreaks or spontaneous reports of diphtheria cases in KZN. And this is a more recent report from 2018 that shows us that there were confirmed cases in the Western Cape, a total of 6 cases of diphtheria. So even though there is a vaccine available, it doesn't mean that those diseases are eliminated. And as I mentioned earlier, because of that immune senescence, well, what normally happens is that even if you've gotten the vaccine, over time and with increasing old age, you are then prone to that specific disease that you're vaccinated against. So this again speaks to that phenomenon over age, as you can see, that the percentage of fully protected goes down. And specifically in those who are over 65, you see that the percentage of fully protected is in the region of 30%, which is different from earlier in life, in your adolescence, where protection is, close to 90%. So similarly, again, with pertussis, there's outbreaks and, spontaneous cases that come about. And this is a report from the NHLS that speaks to that. And again, from Netcare, there was a report published in 2018 that speaks to the increasing number of pertussis cases in South Africa. So even the hospital Netcare is aware of this increasing patterns of vaccine preventable diseases. And so when it comes to the reporting of pertussis, well, what we do know and what we find in scientific literature is that the reported cases, let me just go back to that slide. Reported cases such as this report from the NHLS and from Netcare is only the tip of the iceberg. So if you see here in orange, right at the top, it states that only up to 36% of the cases are reported. So what we probably have on the ground is much, much, much more than what is actually being reported. And again, issue of waning immunity over time, particularly with pertussis, this is more pronounced. And what has been found through serological studies is that after vaccination, even within 5 years, the vaccine is not as effective as it was initially. So there is definitely a need or a case for booster doses or revaccination. Let's quickly talk about our workplace settings. So obviously, working in a hospital setting, we're exposed to ill patients, patients who come with all sorts of diseases, patients who have weakened immune systems, who we can also pass on diseases to. So just the fact that we are working in such settings makes us at a very high risk of these vaccine preventable diseases, such as tetanus and pertussis and diphtheria. Pertussis is particularly tricky because it is often asymptomatic amongst adults. So obviously we know that in babies or young children, pertussis presents as, that distinct barking cough. That is not always the case in adults. And so it is easy to dismiss pertussis to a simple cold or slight cough. And so what often happens is that many of us adults are carrying around these infections. And of course, being in a healthcare setting, such as a hospital, we are exposed to patients who are very ill, who have weakened immune systems, and us as healthcare workers can be a vector for these diseases. And so we know that our vaccines are given in infancy. So the current schedule in South Africa states that the vaccine should be given from 6 weeks, and then there's a booster, from 6 weeks in 3 primary doses. And then there's a first booster at around 18 months of age and a second booster at 5 years. And thereafter, because of that waning immunity issue, it is advisable that that vaccine is administered every 10 years. And for the ladies, it is also advisable that with every pregnancy, you get a booster dose of Tdap. Right, and so again, because of our setting as healthcare workers, it is also advisable that we get booster doses, not just for our own protection, but for protection of our patients. And so it is vital that not only do we get booster doses of tetanus vaccine, but the vaccine, the booster vaccine that we must get should be a combined vaccine that ideally should include diphtheria and pertussis as well. Because as I mentioned earlier, pertussis is normally asymptomatic amongst healthy adults, although healthy adults themselves are carriers for this disease. And so in order to protect our patients, as well as even our household members who have weakened immune systems, it is important for us to get this vaccine. So this slide just talks about a cocooning strategy. Our newborn infants particularly can only get these vaccines only at 6 weeks, right? And so for the first 6 weeks of their lives, they do not have protection against this bacteria, unless maybe their parents are their mothers are vaccinated in pregnancy. But it is a safer strategy to assume that the mothers were not vaccinated, and because of that stance, it is then advisable for us as healthcare workers to then be vaccinated. So you see that there at the bottom in a red circle is our healthcare practitioner who is vaccinated and therefore protects the newborn baby, as well as the weakened, the members of the public with weakened immune systems. So that's it about Tdap. But let me also take this opportunity to remind ourselves about the extended program on immunization, or our routine immunization, that unfortunately, because of the current pandemic, the COVID-19 pandemic, has sort of taken a back seat, and so these articles, these newspaper clips are talking to this phenomenon, where, because all of our energies, as a Department of Health, the public sector, the private sector as well, health sector is focusing its energies on vaccinating against COVID. There is a chance, actually it's been documented now, that there is outbreaks that are happening, so there's measles outbreaks that have been reported. And so what is being described, because of directing our energies towards COVID, is what's known as a twin pandemic. So our previously prevented diseases, such as your measles and tetanus, diphtheria, and all of those, are experiencing an upsurge because parents are not bringing in their children for vaccinations, as well as us as healthcare providers. We are sort of like diverting all of our energy to COVID-19. And so there's policy documents that have been developed by the WHO as well as our National Department of Health that really emphasize continuing our routine immunization even as we are vaccinating against COVID-19. And so the considerations that we should have in general, or in short, is that as much as possible, we should not have mass campaigns. And of course, we should observe our non-pharmaceutical interventions, such as your social distancing, hand washing, and other methods of infection control as we vaccinate. And as health workers, we should really, really, really make sure that we minimize our risk. And if we are obviously COVID positive, we should excuse ourselves from this exercise, as well as from work in general. And so in short, that is my presentation. Please remember that even though we are in the middle of a pandemic, our routine immunizations should still come to the fore, number one. And because of our waning immunity, we should consider as much as possible having our booster vaccines for tetanus, diphtheria, and pertussis. So I will now hand over to Edna for our question and answer section.
Okay, thank you so much, Mr. Sibanda, for such an insightful talk. And I think, it's important having the conversations about waning immunity, with the vaccines, that, the vaccines that we all had as children, when it's not lifetime protection, as we age, the immunity really does decrease. And there really is a need for multiple antigen protection. So instead of giving a single vaccine, like with the tetanus vaccine for your wound management, it's the global standard of care to actually incorporate other antigens, hence the Tdap vaccine. So I don't know if anybody has any questions that they'd like to pose live. Okay, so there's a question in the chat. Edna, there's a difficult question regarding the cost of Tdap in relation to tetanus in ED, especially where WCA is workmen's compensation, injury and duty compensation. Am I correct?
Yeah, I think you're right.
Okay, Mandy, do you want to elaborate? So is this talking about who the cost, like who would pay for the vaccine, or the price difference? I'm not sure I understand the question.
Yeah, so Edna, the compensation commissioner pays a cost per ED visit, not as a for what was done. It's really per visit. And to add the Tdap into the cost of the visit would significantly affect the availability of funds for other stuff within the emergency department. Now, my biggest problem here is who ideally should be getting Tdap. Is WCA our biggest concern of men out there in working, or is their concern more on the tetanus? So there is a organogram of Tdap that needs to be followed in the emergency department. If you look at the cost, everyone looks at cost per incident or per episode, whatever it may be. So that's really, and if you look at the cost differential, it's quite significant.
Mm-hmm.
And I'm not sure that the WCA worker is who comes in after he's injured his hand is the right person for the Tdap. There might have to be different strategies in the ED for different people.
Okay. So the conversation is that, and so let's address the cost. So I'm going to break it down, Mandy, and I'll ask my Sanofi colleagues to help me as well. Okay. So the cost factor, the Tdap is 261, right? But remember, with that 261, it's not a single antigen that's been covered. We have tetanus, we've got diphtheria, and we've got pertussis. Okay. So the idea is that we want to see we're offering value to our patients that are coming in the emergency departments, okay? And secondly, we're finding that globally, the standard of care is that, you know, all the countries are moving away from post-exposure prophylaxis, giving tetanus only, to really covering your diphtheria and your pertussis. Because as Mr. Sibanda just alluded to, we're finding that we're having a lot of vaccine preventable disease resurgence that are coming back up. So the idea is that we want to, as a whole, increase vaccine coverage rates. And we're finding that the idea is that, you know, when patients come in the emergency department, that's almost like, we don't want it to be a missed opportunity that we're only going to be administering tetanus. You know, the idea is that because we have that patient in front of us, we really want to give them the full value and having adults especially covered. Because, you know, in South Africa, we don't have a set adult vaccination schedule like we do with our pediatric segment. Okay. And then secondly, with the workman's compensation question, Meredith, I don't know if you remember what Zinat has said. Can you please help me here?
So certainly, I think that's something that we would need to explore. But I think to Mandy's point, we you know, I think we need to perhaps focus on a different segment. I'm not sure how many workman comps claims do you get in a month, Mandy? I don't know if you can comment, please.
Hundreds of thousands, hundreds.
Okay, so it's a big segment.
Perhaps it is a big segment of all emergency departments, and perhaps it is something that needs to be explored in terms of where Tdap would first hit the hardest, and then afterwards you could look at other, you know, so you start with the 80s or you start with those. I think it was that picture that was shown about the reduction of immunity over time. So perhaps you have a very targeted group initially, mothers and over 50s, and then you work on other groups from there.
Yeah,
Mandy, if I can maybe comment on this point too. I'm Tina Smurray. I'm the medical head for Africa for Sanofi. I think, you know, I hear your point about going for a targeted approach, but that could lead to quite a complicated algorithm, simply because, you know, where this is positioned is kind of in the scope of life course immunization, which is a pretty new thing that the WHO have started focusing on. And if you then have to say, okay, within the adult population, or let's say the post-pediatric population, if we need to identify certain risk groups, certainly then I guess for pertussis and diphtheria specifically, you know, you make a valid point on pregnant women, because that's something that's a focus in general in terms of vaccination in pregnancy. But beyond that, sort of to attribute risk to particular at-risk groups is going to become tough, because then do you say over 50-year-olds because they're in contact potentially with infants because they've got grandchildren or whatever it may be? I'm just thinking it could complicate your algorithm in terms of assigning risk to people when I guess the underlying sentiment here is that immunization is not for life and can't be exclusively for pediatrics, and really should be a life course practice. So that's just something to consider where and to Edna's point, in the emergency care facility, it's an opportunity to vaccinate not only for post-exposure prophylaxis, but for this concept of vaccination throughout life.
So that's a very interesting concept which has never been heard in South Africa, or at least I've never heard a concept of vaccination for life, and that's something we're going to have to do a lot of education around. And obviously with the current controversy around vaccinations, we need to ensure that there's no confusion as to this vaccination for life I really like the
100%.
concept, but it is something we're going to have to educate, and perhaps something we should do. Is run a very big vaccination for life sort of campaign for all those anti-vaxxers out there, you know.
Right. No, good point.
Thank you.
Good point.
Edna, I had another question, but I can't remember what it was now.
Okay, so while you're thinking, and it's probably gonna come back, my apologies, I didn't introduce the team. Meredith Dooley is our franchise lead from Sanofi, and Tina Smare is our head of medical for the region. Sorry. Okay.
No problem. Thank you.
Okay.
Thanks,
While you're still thinking, Mandy, can I tackle the next question?
Please do.
Okay. So question on the chat, how long after COVID and or COVID vaccine should you wait before Tdap? Mr. Sibanda, can you address this, please?
Okay, yeah, sure. Edna, our information or our knowledge on COVID-19 vaccine with other vaccines is still a little bit limited, because obviously this is a new disease, new vaccine. And so the research is ongoing. What I can say for sure is the influenza vaccine. And the influenza vaccine is important because it is perhaps a reference vaccine, if you like, when it comes to COVID, because there's possibilities of cross-reactivity. And so it will be the most useful indicator in terms of giving it simultaneously with the COVID-19 vaccine, or knowing the time period within which to separate the two. So the guidelines for influenza initially were saying that there should be a 4-week gap between the influenza vaccine and the COVID-19 vaccine. But I read now the updated guidelines say that a 2-week interval between influenza and COVID-19 vaccine is acceptable. And so, as I mentioned earlier, the influenza vaccine can be used as a reference vaccine for all the others because of the similarity of the influenza virus with, COVID-19 vaccine, COVID-19 virus, and the possibility of cross-reactivity or any untoward interactions.
Okay.
So I think a 2-week gap minimum is acceptable for COVID-19 vaccine with any other vaccine. So that's my response in short. Thank you.
Okay, perfect. Thank you. Tinas, anything to add?
Yeah, maybe I can just say, I mean, Mrs. Van is 100% right there, that this is sort of a developing field in terms of co-administration with COVID vaccines. There's, in terms of hard evidence and data to support co-administration, there's multiple co-administration studies being run globally at the moment, and particularly on influenza vaccine, because we anticipate that the co-administration of these two vaccines will obviously become very topical in the future as well. So the evidence is coming. I think what various referencing bodies have now done is taken kind of different approaches. In some senses, if we look at our local guidelines from the NICD, you see there's a recommendation for a 14-day interval. What recommending bodies such as the CDC have done is they have gone on, I would say, the body of evidence that exists for administering inactivated vaccines together. So they recommend co-administration of influenza and COVID vaccines, not on the basis necessarily of evidence for co-administration, but rather saying these are two inactivated vaccines by classification. Experience has showed us that inactivated vaccines can be administered together, should just be given at different sites. So people take different approaches on it. It's something I think no one's going to put their head on a block now to say this is definitely how one should approach it. I think reference your local referencing body is my recommendation, but certainly keep an eye on it because it's going to evolve as new evidence comes to the fore.
Okay, perfect. Thank you so much. Mandy, did you remember your question?
That actually was my question, by the way.
Ah, okay. Well, I don't know if anybody else has a question that they feel confident enough to ask live.
Oh, these are ED girls. They are confident. I want to ask Mr. Sibanda one other question, which doesn't really pertain to this vaccine, but in terms of his PhD, is if he has an opinion on the anti sort of stance by many South Africans, including young people. I've just come from Wits, where we ran a vaccination center for COVID, and in 3 weeks had only 2,000 students uptake. If you think they've got 15 to 20,000 students at the university. I was just wanting to ask, I know he's doing his study in the elderly or in the geriatric population, but I mean, he must have an opinion. He's widely read on what do we do to improve this stance. Maybe we should take him with us wherever we go so he can chat to people. Mr. Sibanda?
Thanks, Mandy. And you raise a very important issue that was actually identified by the WHO even before the pandemic itself. So already in 2019, the WHO identified vaccine hesitancy as a threat to global health, as one of the top 10 threats to global health. So, and you find this phenomenon is just not, amongst, the poor and illiterate. It is perhaps even greater amongst the so-called middle class and educated people, who you probably expect better from because, they've been exposed to an education and all of that. In terms of countering vaccine hesitancy, I think we, particularly us as healthcare workers, have got a lot of work to do. It is really unfortunate that a lot of us health workers or scientists, virologists, epidemiologists, the works, the whole body of science, if I can say, of medical science, is not so well trained in communication. I've read a few of the articles about COVID-19 and about the vaccine as well. And a lot of them, I could say perhaps 8 out of 10, do not speak at the level of ordinary people. It's articles are full of, scientific jargon and, a whole lot of difficult concepts for ordinary people to understand. And also with regards to the communication strategy, a lot of the anti-vaxxers, they've got so much energy. I mean, if you go on Facebook and other social media, a lot of the anti-vaxxers, they post, without ceasing, literally. So on a day, they will post 5, perhaps 10 messages about the dangers of COVID-19 vaccine. Whereas us as healthcare workers, or even higher up from a national department perspective, you probably hear one messaging maybe in a day, or if you're lucky, maybe 2 or so. So we really have a lot of work to do in terms of the right type of communication. So that's my opinion on anti-vaccination.
Thank you very much. I really appreciated that, but it also pertains to this Tdap, because they're going to be asked in the emergency department many questions about why they should change and use Tdap instead of something else. And so you've highlighted something that I'd like to run an article in the education for, and I think we would have to do that for Tdap as well in the EDs. Very interesting. Thank you. Thank you.
Great. Thank you.
Okay, thank you so much. Are there any more questions? Last chance, any last takers? Okay, I don't think there are any more questions. Let me just check. Oh, okay. Thank you so much for the team and Mandy for affording us this opportunity to engage with the emergency department staff, and for Mr. Sibanda for an early start to his day and such fruitful engagement, and for the tough questions, Mandy. So thank you for always making us think. Okay, super. Mandy, can we close, or do you have any closing comments? Or can
no, I was just looking for my thank you. I was just looking for my unmute button. Mr. Sibanda, and to Sanofi and your team, very interesting discussion, which we must now take forward on a one-on-one basis to see how we can implement the strategy within the emergency department. So we thank you immensely for the education. I'm going to put this presentation onto Netcare, the Netcare platform, as well as onto what's it called? That platform we normally put it on. I can't think. It's because of my age that I don't. But I'll let you know where the link is. And we really appreciate it. It was an excellent presentation. We really, really appreciate it. Thank you, everybody. Bye-bye.
Cheers,
Thank
cheers.
you.